Okay, I think we'll go ahead and get started. We may have some folks that join a little bit later, but as usual, I will give us a quick overview of the logistics for the webinar for the next hour. I would like to welcome everybody today to our education series that the HTRC is hosting. I'm Molly Brown from the Heartland Telehealth Resource Center. We're glad you're joining us for this series today focused on telehealth billing, coding, and policy. Just a few reminders, I'm sure many of you have already heard this, but this session is being recorded and we will share it with you afterwards. Your microphones have been muted, so if you would like to ask a question during the presentation, please unmute, or you can use the chat boxes. We'll be monitoring that as well. Your completion certificates will be emailed. It is important to sign on with your first and last name so we can identify you. You can rename yourself by using the 3 dots on the Zoom profile to change your name or add your last name if you need to. So let's go ahead and get started. I would like to introduce Rochelle Marting. Rochelle is a local attorney who is also a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing and reimbursements, HIPAA privacy and security, health information management, and regulatory compliance. We're happy to have her here today to talk about long-term care service delivery and billing. Now I will turn it over to Rochelle.
All right, thank you, Molly. It's been a busy couple of months in long-term care and in telehealth and with policy and rulemaking in general. So I'm excited to talk about some things that are going on in both the intersection of telehealth and long-term care this afternoon. One of the things that I've done, spent the last week or so getting ready for Monday and Tuesday of this week was the American Health Information Management Association Advocacy Summit with senators and congressional representatives. So we had a chance on Monday to get some insight on what's going on in the world of telehealth and HIPAA privacy and information blocking and things that deal with electronic exchange of information, very much impacting telehealth services and getting some updates there. And it sounds like there's more to come on the regulatory front there, just some things that the agencies are working on that we could see in rulemaking in the coming months. So what I want to talk about today specifically with long-term care and with telehealth is kind of the start of the long-term care and specifically skilled nursing facility episode, right? When the patient's coming from an acute care location, coming into a long-term care facility, and some of the rules and requirements in a normal environment and how they've been made flexible during the public health emergency, and what may happen when the public health emergency goes away. The status of the public health emergency as we stand today is that it's set to either expire or potentially renew April, now I'm forgetting whether it's the 17th or 19th next month, or we're almost into April, unbelievably. And if it were to renew, it would be for another 90-day period taking us into July. And then we would wait and see what happens over the summer to see if it expires or renews at that time for another 90-day period. All signs are pointing to another renewal. I would expect we would see some guidance from the federal agencies if it looked like it was going to be allowed to expire in April. Of course, crazier things have happened, but that's kind of what things are signaling. And I have a just prediction wise, if it were going to be allowed to expire, July kind of seems to be a prime time that I think will really be focused on a critical decision on whether the public health emergency continues or not. And the reason I say July, barring another variant or surges that complicate the wind down of the PHE, is that in March, we had a Consolidated Appropriations Act of 2022 passed. And in that act were the extensions of several telehealth flexibilities that were created during the public health emergency. And we talked about this last week. So if you want to do a deep dive into what those were and how long they've, which flexibilities have been extended after the public health emergency ends, go check out that session from last week. But the time frame of the extension for 151 days just happens to perfectly align with the end of calendar year 2022 if the public health emergency in July is not renewed. So for me, that kind of signals that's the direction that the administration may be thinking and heading, barring any exacerbations of the COVID-19 virus. So we're going to talk about long-term care and initiating long-term care in the skilled nursing facility setting and kind of what those flexibilities look like, as well as what parts of the bundled package of a Part A skilled nursing facility stay are sort of primed to be delivered in a remote or a telehealth type environment, and what the coding and billing surrounding those services may look like. I also want to talk about a couple of aspects of both the therapy component of a skilled nursing facility stay, or patients who are not in a Part A stay, but who may still be receiving therapy within the skilled nursing facility, what that may look like, and other care management services that the physicians, the nurse practitioners, or others that are coming into a long-term care community may be able to look at and think about as possible services that they're providing, in addition to just the mandatory 30, 90-day skilled nursing facility visits. So we'll take a look at that also. So I want to start with the patient coming into the long-term care community, skilled nursing facility in particular, after an acute stay. Typically, prior to COVID, and as soon as the public health emergency ends, there's a requirement that in order for that skilled nursing facility stay to be covered by Medicare as medically necessary, there has to be a qualifying 3-day acute care stay preceding the skilled nursing facility stay. And usually it's essentially a transfer from the acute care facility into long-term care, but there could be a gap in between, and that skilled nursing facility stay has to start within 30 days of discharge from the acute care facility. That requirement for a qualifying 3-day stay has been waived during the public health emergency, but the day that the public health emergency ends, as of right now, that qualifying 3-day stay requirement will go back into effect, meaning that entire stay from the facility side could be affected or at risk if there isn't a qualifying 3-day acute hospital stay before coming into the skilled nursing facility. This isn't directly related to telehealth, but I work with a lot of long-term care communities, and I've worked with them on several claims that have been denied for not having a qualifying 3-day stay. And if you haven't already incorporated into your admission process documentation of getting the duration of stay from the acute care facility, including the order to admit the patient as an inpatient, so you can see the timing of when that order was created and the date of discharge, because if I remember correctly, the date of discharge doesn't count towards the 3 days for the hospital stay. And making sure, particularly with short stays that could either be 2 or 3 or 4 days, that we're really calculating that a 3-day stay has actually occurred, building that into your admission process after the public health emergency ends, so that your entire stay isn't denied as non-covered for sort of an administrative or clerical error, would definitely be a process I recommend incorporating, because that requirement is coming back based on what we're seeing right now. So then I want to talk about you get the patient into the skilled nursing facility from acute care. There's a qualifying 3-day stay. Now we've got some initial long-term care visits from the patient's attending physician or patient's primary care physician, and or other healthcare providers that may be coming into the facility to see the patient throughout their stay. And what happens when we're wanting to provide some or all of those services via telehealth from those healthcare providers? Long-term care facilities, even outside of the public health emergency, so before and after on a permanent basis, are eligible originating sites for telehealth services, which is great. That means in terms of the skilled nursing component or unit of the facility, When a patient is registered and located in that area, and a distant site professional wants to deliver a telehealth service to a patient in a skilled unit of the facility, then that's potentially possible if all other telehealth requirements are met. However, if the facility is one that has different units or different levels of care, like independent living and assisted living, independent and assisted living locations are not eligible originating sites, where a distant site professional, like a physician, could typically provide a telehealth service outside of the public health emergency. Now, we know that during the public health emergency, the definition of originating site has been expanded to include the patient's home as an eligible originating site. So right now, during the public health emergency, particularly in independent and assisted living, if that is the patient's home or place of residence, that potentially could be an eligible originating site for telehealth services. There's a little bit of a catch and a little bit of a gray area that I want to call out there, that during the public health emergency, the way originating site is defined for telehealth doesn't say that any location where the patient is located can be an originating site. It adds the patient's home as an eligible originating site. So you think of an apartment, a single family house, a duplex, those types of things are obviously could be the patient's home. It gets a little bit trickier and more ambiguous with independent and assisted living, because when we're reporting those locations on a claim form, there is a place of service. Now I'm forgetting what it is off the top of my head. It's not 11, 12 potentially, for the patient's home. There is a separate place of service for an assisted living facility, place of service 13, that's different than the place of service code for a patient's home. So there has been a question, I would call it, or a gray area on whether a patient living in an assisted living facility as their place of residence and whether that can qualify as the patient's home for telehealth service. So if that's something that your healthcare professionals are providing in the long-term care setting, I would suggest doing some due diligence on maybe some outreach to CMS or to the local Medicare administrative contractor in confirming that that is appropriate to consider as the patient's home when it's assisted living, and what place of service code should be used, whether it's 13 or the place of service code for the patient's home. There was some guidance, not directly related to originating site, but in a different COVID billing topic that was in the Federal Register. And I'm just going to read this so I get it correct, that suggests to me that assisted living facilities could act as the patient's home when it comes to eligible originating sites for telehealth. And this particular guidance was talking about an add-on payment for COVID-19 vaccine administration. And it said that a home can be a private residence, temporary lodging like a hotel, a motel, a campground, a hostel, or a homeless shelter, an apartment in an apartment complex, or a unit in an assisted living facility or group home, or some other patient's home that is made provider-based to a hospital, if that's how a hospital is billing. As such, a home can be a domiciliary or rest home, meaning a facility that provides room and board or other personal assistance services, for example, an assisted living facility. So while that guidance was not directly talking about telehealth, I think it's instructive on, during the PHE, how Medicare might interpret the assisted living facility as being an eligible originating site. So Medicare Advantage plans, however, have had some regulatory flexibilities to offer telehealth in an expanded way above and beyond what fee-for-service or regular Medicare offers in long-term care's places of service specifically since 2019. So you may find that in Medicare Advantage plans that you're contracted with, you actually have greater flexibilities on what services can be delivered via telehealth and how under those plans and under your contracts than what you would have under straight Medicare. So this is talking about the professional billing for a moment, and their initial skilled nursing facility visits and subsequent skilled nursing facility visits to a patient who's in a skilled nursing facility. There are kind of two categories of codes for that. One for the initial visit by that provider to the patient in skilled nursing, and then subsequent thereafter. The codes for an initial nursing facility visit, this range of codes just vary by how complex that particular patient, that particular visit is. And they have been added temporarily to the list of eligible telehealth services during the public health emergency. So if I can see if I can pull this up here, can you see the Excel spreadsheet here?
Yes.
Okay, got a thumbs up, great. So this is the current list of telehealth services that are eligible to be provided by to patients with Medicare. And this is the range of codes for that initial nursing facility care. But you'll see here that there are temporary additions during the public health emergency. And right above that, you see that there are some codes that have already been identified as that they will continue to be covered through December 31st of 2023 at a minimum, unless they're permanently added as telehealth prior to that. Initial nursing facility care codes do not have that extension. That means as of right now, the day that the public health emergency ends, initial skilled nursing facility visits will have to be provided as in-person services and will no longer be covered as telehealth services. The timing requirement for those is that the physician is seeing the patient. Typically that's in person. Right now that can be via telehealth on admission or as soon as practicable thereafter. And that's certifying the need for skilled nursing facility care. That is all of the requirements for skilled nursing, that it requires an inpatient level of care, skilled nursing and or therapy 5 days a week. And there are some requirements there as part of that initiating visit. They're provided and they're billed by someone that will be the attending provider for the patient during the skilled nursing facility care episode with knowledge of the patient. That in-person visit requirement is waived during the public health emergency, and that's different from the telehealth list. So under the skilled nursing facility regulations and conditions of participation, it's required there that the initial visit by the provider be in person. That regulatory requirement is waived during the PHE and will return during when the PHE is over, that they have to be in person. And that's why those codes for an initial nursing facility visit will also go away from the telehealth list the day that the public health emergency ends. Subsequent to that, there are mandatory subsequent nursing facility visits periodically throughout the skilled nursing facility stay, and additional visits can be covered if they are medically necessary outside of the mandatory visits every 30 days or so once the patient is in skilled nursing. Those even before the public health emergency can be delivered via telehealth and will continue to be allowed via telehealth after the public health emergency ends. So back on my telehealth list, those fall in this category. And you see there's no caveats there that they will go away when the public health emergency ends. So those are permanently allowed via telehealth by the provider. They typically have a limit on how often they can be provided via telehealth. So whether it is a mandatory 30 or 60 or 90-day visit, or if it's a medically necessary visit with the patient more frequently than that. If being provided via telehealth, before the PHE, there was a restriction that they can only be done via telehealth at most every 14 days. And so if the patient has to be seen more often than that, often I'll see patient visits every 3, 4, or 5 days, particularly the closer in proximity to admission and acute care. We tend to see those visits more frequent, and then they start to lengthen out in between visits as the patient begins to stabilize and their medical conditions improve. During the public health emergency, that limit on how often you can provide a subsequent nursing facility visit via telehealth is waived. But the day the public health emergency ends, that frequency limit will go back into effect. The other thing to keep in mind is that it used to be once every 30 days. In, January 1st of 2021, the frequency of every 30 days was proposed to be decreased to once every 3 days. And Medicare sort of cut that in half and said once every 14 days, or essentially once every 2 weeks, you can have a telehealth visit. That will go back into effect when the PHE ends. Okay. I want to talk about another rule dealing with the providers that are coming into the long-term care community to see patients that changed just this year, January 1st of 2022. There's a concept in Medicare billing called split or shared visits. And that means that on the same day for the same patient, both a physician and a non-physician practitioner, like a nurse practitioner or a physician assistant, see the same patient on the same day. And the concept of split and shared visits means that those two providers can combine their documentation, combine their work that may potentially increase the total level of care or the level of service that can be billed, and also could allow the physician to be the billing provider for that combined visit between the two professionals, allowing for the physician rate of payment rather than the non-physician practitioner rate of payment that is only 85% of the physician rate. So now, as of January 1st, 2022, split and shared visits can be done in the skilled nursing facility setting, where previously they were not allowed to be done in the skilled nursing facility setting, which meant each provider individually had to look at their documentation and decide a level of service. And when they are in the same group practice, only one of them could bill, and oftentimes that was limited to the nurse practitioner and a lower rate of payment being billed for that service. So let me give just a little bit of background and context on where we were with split shared visit rules and how we got to where we are now, and what the rules of the game are in deciding who gets to bill for the service and the rate of payment, and how that ties into telehealth. So Medicare generally, not just limited to telehealth, not just limited to long-term care, but more broadly, has a rule that it will only pay for one evaluation and management service per patient, per day, and even per provider. But Medicare also has a rule that multiple providers of the same specialty and the same group practice are treated as the same provider for billing purposes. So if I have Doc A and Doc B going into the long-term care facility, one in the morning, one in the afternoon, they both work in the same group practice, same specialty, only one of them is going to get to bill for that patient's visit that day and be paid for that patient's visit, because they're treated as the same individual. Now, their documentation could be combined to potentially increase the level of service or the code that is billed, but only one of them gets to bill for that. There are some narrow exceptions called concurrent care rules, which essentially is like when there's different specialties involved, that more than one evaluation and management service could potentially be billable. I don't see that come up often in the long-term care setting though, so we won't get into those concurrent care rules today. Each of them have to perform a substantive portion, and I have that in quotes because the definition of what constitutes a substantive portion of a face-to-face visit has changed as part of these rules that went into effect January 1st of 2022. The previous rules, including this concept of split or shared billing, could not happen in a long-term care or skilled nursing facility, were only found within Medicare administrative manuals. They never went through the rulemaking process. So they weren't published in the Federal Register as a proposed rule, open for public comment, and then finalized as a rule. And in 2020, there were regulations on how to make regulations. And so they're called the Good Guidance Regulations, and essentially looks at something called the Administrative Procedures Act that really created this foundation of a proposed rule, public commenting, and final rulemaking for agencies like Health and Human Services and Medicare to create rules, and that you can't create new rules through manuals, and you can only clarify or interpret things in manuals, or for Medicare, for example, Medicare could give instructions on exactly how to effectuate a rule on a claim form and what things you need to put where on the claim. As part of those good guidance regulations, there's now a mechanism to request or to apply for rules that didn't follow the good guidance rulemaking process, and to have Medicare or other agencies take a look at those. And split shared billing was one of those, because it had only been found in a manual previously, and someone applied to have CMS look at that and say, hey, this didn't follow that rulemaking process. And Medicare agreed. So May of 2021, Medicare withdrew all of these rules around split shared billing that was in its manuals, proposed a rule as part of the physician fee schedule, finalized that rule, and as part of that expanded how split and shared services can be provided, now encompassing skilled nursing facilities and long-term care that were never able to utilize this particular billing concept that may allow physicians to bill for services that were in part provided by non-physician practitioners. So the way that this works now in long-term care for a service that is in part provided by a nurse practitioner, non-physician practitioner, as well as a physician, is that it can be done for both the initial and the subsequent nursing facility codes are eligible. Under the conditions of participation for skilled nursing facilities, there are some visits that have to be performed in their entirety by a physician. So they could not, cannot be provided as a split or shared service. So the mandatory visits every 30 days for the first 90 days, every 60 days thereafter, those have to be performed in their entirety by a physician, cannot be provided in part by a non-physician practitioner. Or if they are, we can't consider the non-physician practitioner's documentation in determining the level of service that is billed by the physician. So essentially, the non-physician practitioner is doing a non-payable service. They can still do that, they just can't bill and be paid for it. After that initial visit that's personally performed by the physician, the subsequent mandatory visits can alternate between a physician and a non-physician practitioner. So for those alternate mandatory visits that could be performed by a non-physician practitioner, they could also be performed as a split or shared service, which means that the non-physician practitioner can come in and do a lot of the work, followed by a physician who performs a, I'm going to put it in quotes, substantive portion of the visit. And if requirements are met, that visit could still be billed under the name and number of the physician and be paid at the physician's rate, 100% of the allowable versus 85% of the allowable. That concept also extends to telehealth services, this idea of a split or shared service. So the nurse practitioner does part of the service as a telehealth service. The physician performs a substantive portion of the visit. It could still potentially be billed by the physician, even when all or part of that visit is done in a telehealth format. So one, particularly in facilities that have a continuum of care from independent to assisted to skilled, this billing mechanism, this concept of a split or shared service between a non-physician practitioner and a physician that could potentially be billed under the physician's name and number, is only eligible in a facility setting. So it's only eligible in the skilled nursing component of the building. It's not an option in independent living or assisted living. Okay. The other thing that when all or part of that visit is done as a telehealth service, if I can get my little, get my little highlighter up here. When I say a substantive portion of the visit, it doesn't necessarily require that each of the providers have a face-to-face, and face-to-face can be done via telehealth. It simply requires that the physician or the billing provider perform a substantive portion. So in the context of telehealth, the physician doesn't necessarily have to join as part of the telehealth service. If that is done by a non-physician practitioner, the way that the physician may potentially still be eligible to bill the telehealth service is if the physician still spends a substantive portion of time, likely reviewing the patient's history and performing medical decision-making, which doesn't necessarily mean that the physician is having a interaction or a face-to-face visit with the patient. The way that substantive portion of the visit is now defined is that the billing provider their time has to comprise more than half of the total service as combined between the physician and the non-physician practitioner. That likely is a change in documentation to professionals that are seeing patients in the long-term care setting who may not typically document the duration of their visit. But if this is a model that is being provided and you want to consider billing under the physician's name and number, they need to be documenting their time, and you need to have a mechanism to compare doc's time to non-physician practitioners' time and only bill under the physician's name and number when that time is greater than the time documented by the non-physician practitioner. That is true even if the level of service being billed is calculated based on history, exam, and medical decision-making. Time has to be documented to decide if the physician is going to be the billing provider. Now, if you end up billing these split or shared services under the non-physician practitioner name and number, and there's documentation from the non-physician practitioner, that is not as concerning to me if time is not documented, but time is absolutely critical if you want to be using the physician name and number to capture the higher rate of reimbursement for the physician. Now, knowing that this was likely representing a considerable change in professional documentation in the long-term care setting, because this was never an option in skilled nursing facilities before January 1st, and providers weren't typically documenting their time prior to January 1st. This year is a transition year in deciding which provider's name and number can be used to bill for that service. So this year and this year only, you can use this time, which provider's time was more than 50% of the total duration of the visit. Or as long as the physician provided one of the three key components, history, exam, or medical decision-making in their entirety, and at the level enough to independently, without looking at the nurse practitioner's documentation, can support the level of service billed. Then in 2022, you could also bill under the physician's name and number. But as of next year, January 1, 2023, both providers need to be documenting their time, and you can only bill under the physician's name and number if his or her time in the record exceeds that of the non-physician practitioner for the same patient on the same day. Clear as mud, right? When we are billing using this split shared mechanism, and we are choosing to bill under the physician's name and number for a combined visit, because the physician's time exceeds the non-physician practitioner's time, or for this year only, the physician has provided in full one of the key components, history, exam, or decision-making. We also this year have to start applying a modifier to that visit when it's billed under the physician's name and number, modifier FS. That identifies the service as a split or shared visit. If the physician is the only provider seeing the patient that day and billing under the physician's name and number, you do not need to add modifier FS to the service. That is only identifying a visit that's done as a split or shared service between a non-physician practitioner and physician on the same day for the same patient. That modifier was newly created this year, and I will say it has my antenna quivering, because with that modifier being applied, it is very quick and easy for a Medicare contractor to identify claims that were billed under this mechanism, which means it's really quick and easy for a contractor to request records and to audit and review these services. So I think the creation of that modifier, it sort of signals to me that that's something I would expect contractors to be reviewing in the future, to make sure, one, that time is documented between the two providers, and that when we are billing under a physician's name and number, we're following the rules on when and how we can do that.
Rochelle?
Yes.
We have a question in the chat. What about billing for telehealth services such as social work, case management, mental health, health and wellness coaching, and more?
All right, so Helen, that perfect seed question. Your check's in the mail for the perfect segue to the next couple of slides here. So the general theme, I'll tell you, is that those services that are typically part of a skilled nursing facility consolidated bills, it's part of their per diem payment, can be provided remotely or as telehealth services. And the great thing about some of the guidance that we got during the public health emergency that was never really clarified before is that that's actually a permanent rule. That's not limited to the public health emergency. However, even though the social worker services, let me pull up the chat again, social work, case management, those things that are part of the per diem payment for the skilled nursing facility, even though they can be done remotely, even outside of the public health emergency, does not change the fact that they are part of the facility's consolidated bill, which means they can't be separately billable just because they're being done as a telehealth service during the PHE or even after the PHE. So this is one of the FAQs. The timing of your question could not have been more perfect. This has been true back since the beginning of the PHE in March of 2020. In order to help minimize unnecessary person-to-person contacts, could social workers, and I would say all of those other disciplines of providers that you mentioned in your question, can they conduct their visits to patients in a Part A skilled nursing facility stay remotely rather than coming on site? And then part two, is that part of the consolidated bill? So yes, the option to do that remotely has always been there before, during, and after the public health emergency. That's a permanent option you have in the way you provide those skilled nursing facility services. It is still part of the consolidated bill that is not reported separately. One other thought I had as I read this FAQ that's sort of tangential to the idea of telehealth and telehealth coding and billing was that we know back in, I want to say November, we had CMS issue their interim final rule on COVID vaccine mandates in the long-term care and other facility settings. And long-term care, at least with the organizations that I work with, has been hit pretty hard by those mandates. And I think particularly in rural areas, which very much may apply to this group in Kansas, Missouri, and Oklahoma, had a little bit of a challenge getting folks vaccinated and or meeting a medical or religious exemption under the vaccine mandates. One exception to those vaccine policies is if the individual works 100% remotely. So let's say, for example, you had a social worker who is an employee or a contractor providing services to the skilled nursing facility, but who did not want or could not get vaccinated for various reasons, and or didn't have a religious or medical exemption or meet the requirements for that. That individual can still provide the social work or other services 100% remotely, and you're not affecting your vaccine rates as part of that policy. So that's an option too that you may consider as a potential accommodation or flexibility for individuals providing these services that may have some challenges under the vaccine mandates. The same concept, I think this was in Helen's question as well. How does this work with the therapy disciplines? So physical therapy, occupational therapy, speech therapy. If you want to dive more into how telehealth works for those therapy disciplines, we had a session on that as well a few weeks ago. And particular to the long-term care setting, we've got some really helpful guidance from CMS in their telehealth FAQs. That similar type question to avoid person-to-person contacts during the PHE. Could some of those therapy disciplines provide their evaluations or other therapy services remotely during the public health emergency? Yes, and particularly for patients in a Part A stay, that's part of that consolidated bill where therapy services are not billed separately, although they may affect the I'm forgetting the term. It used to be a RUG, and now I can't remember the abbreviation for the new complexity categorization for skilled nursing facilities. That yes, that can be done remotely during the PHE based on the clinician's, professional judgment on the appropriateness of doing that. However, if it's part of the consolidated bill outside of the PHE, it continues to be part of the consolidated bill during and after the PHE when that's provided. I do want to call out down at the bottom here, though. Let's see if I can get my highlighter going. This may be a little bit unique for the therapy disciplines when a patient is not in a Part A stay, meaning the patient, the therapy services can potentially be billed as Part B services. During the public health emergency, physical therapists, occupational therapists, and speech therapists, as well as audiologists, were added as eligible distant site practitioners, where prior to the PHE, for patients in a Part B stay or not in a Part A stay, they didn't have the option to deliver those Part B therapy services via telehealth. Right now, during the public health emergency, they do. They're eligible distant site practitioner. Those codes have been added as temporarily covered codes on the Medicare telehealth list. And with the Consolidated Appropriations Act of 2022 that was just passed a week or so ago. The pop-up webinar that we did last week has more details on that. Those disciplines will continue to be eligible to provide distant site telehealth services for 151 days after the public health emergency ends at a minimum. And I'll say also that adding PT, OT, speech therapy, and audiology as distant site providers is that is found in many of the various telehealth bills that have been proposed at the federal level to make them permanently eligible distant site practitioners. So it is possible if one of those bills are passed within 151 days of the end of the public health emergency, that there may be no gap in coverage, and those therapy disciplines can continue to provide and separately bill for telehealth, teletherapy services to patients in a Part B stay after the public health emergency ends. So lots to come in the therapy disciplines. I'll switch here back to my telehealth list, and if I can remember my codes correctly, we'll get down here to the modalities of therapy, the therapeutic exercise, gait training therapy, those time-based therapy codes are on the telehealth list, and you'll see these are actually among the codes that will continue to be covered as telehealth services through December 31st of 2023. However, where we are today with Medicare, PT, OT, and speech therapy will only be covered as distant site practitioners who are eligible to bill teletherapy for 151 days after the PHE ends. So when that deadline occurs, let's say it's December, let's say the PHE ends in July. Therapy providers are allowed as distant site professionals for 151 days after that, so through the end of this calendar year. Therapy providers seeing patients in a Part B stay or otherwise, you will still see these codes on the telehealth list, but unless there is a change from Congress or HHS, the therapy disciplines will not be eligible distant site practitioners going into 2023. So that, I think, is going to be a real point of confusion for therapy in the next calendar year. On the Medicaid side, though, I wanted to point out two, just kind of, I don't know if this was an oversight or intentional, but it's kind of unusual. The KMAP policy, and I've got it linked here that you can access after the session, also allows these therapy disciplines to provide services under the Medicaid program as telehealth. And this is in effect until rescinded. Here we go. Effective date, it's in effect until rescinded, and I've not seen any policies or bulletins rescinding this ability for the therapy disciplines to continue to provide telehealth under the Medicaid program. I want to add, though, that on this list, code 97140 is a code that I'm not really sure how this works. So if we've got any therapists on the line, they can help me with this. Manual physical therapy techniques can be provided as a telehealth service under the Medicaid program. That code, though, 97140, is not on the Medicare list of telehealth services. Missouri, you've got something similar under the Missouri bulletin. It also has not been rescinded. It went into effect May 21st of 2020. As far as I can tell, there's been nothing to rescind this. Here's the list of the different therapy codes that are added. 97533 down here for occupational therapy is covered for Missouri Medicaid, but is not on the Medicare list of covered telehealth services. So I just wanted to point out those two kind of unique variations, I guess, or differences between Medicare and Medicaid. So I want to talk about also some other evaluation and management type services that are sort of evolving models of care in the long-term care setting that you may consider with the physicians or other professionals that are seeing patients, whether this is skilled, assisted, or independent living, long-term care environments. There are codes called transitional care management that are eligible for reimbursement under the Medicare program. It's not limited to patients going into the long-term care setting, but it's available to patients in the long-term care setting. And I think it works really well in long-term care because you inherently have a patient who is transitioning in levels of care from acute into skilled in many instances. And transitional care management is really managing that care transition between hospital or other acute care location into a different environment. That may be skilled, but it could also be assisted independent living communities. There's two different codes for this, and they vary based on the patient's complexity, really, whether it's moderate or whether it's high complexity. And as part of the transitional care management service, there is a face-to-face visit with the patient within either 7 days or 14 days of the transition from acute care. So it has to happen within 7 days if it's a high complexity patient, 14 days if it's a moderate complexity patient. But that face-to-face component can be provided via telehealth. So we're going to see, if I go back to my list, 495, those codes are permanently on the list of eligible telehealth services. This is during as well as after the public health emergency. This may be something to consider. And what you do is you have a face-to-face visit, which can be via telehealth. This is separate from the initial nursing facility visit service. And they can't be done in conjunction. They actually have to be distinct times, distinct encounters. We have communication with the patient within 2 business days of discharge. That does not have to be a face-to-face communication. That can be calling the patient at skilled, assisted or independent living, or at home for that matter. How are you doing? Have you filled your meds? Have you, checking in with the patient on those discharge instructions and making sure those are being followed. The complexity of the visit is either moderate or high. And the way we determine whether a visit is high or moderate complexity has also changed effective. This is actually effective 2021. And there are new sort of medical decision-making tables on how we calculate that. And this is really what we're looking at. We look at how many problems the patient has. Are they stable? Are they exacerbated? How many types of diagnostics are we looking at? Labs, radiology, et cetera? Are we having to coordinate with other care providers? And are we managing prescriptions and so on? We've got the face-to-face, that can be telehealth, but that face-to-face visit is part of the payment that you get for a transitional care management service. So it is not separately payable as like an office visit or a home visit or a skilled nursing facility visit service. I won't go into a lot of details on these other types of care management services. I just wanted to highlight them here because I've seen a lot of different long-term care settings starting to think about how they could take some of these concepts that were almost designed for a primary care setting, but how they could be incorporated into the long-term care model to take better care of patients that are in independent, assisted, or skilled nursing facilities. We've got sessions from HTRC that are dedicated to the care management category. So if you're interested in any of these, you can check those out to do a deeper dive on chronic care management, separate and apart from the skilled nursing facility mandatory visits or the medically necessary visits when a patient's labs are out of whack or they're having an acute acute delirium or acute mental status changes, and so on. Chronic care management is really focused on managing the patient's chronic conditions, and it's happening mostly behind the scenes. There is some discussion with the patient throughout a calendar month, but you're doing things like managing medications behind the scenes for the patient as well. Behavioral health integration has also been a growing trend in long-term care, where behavioral health specialists can see the patient and coordinate with the primary or attending physician in the long-term care environment, but with a focus on managing mental and behavioral health conditions for the patient. Or psychiatric collaborative care is sort of the same concept, but it's a little more complex. It involves typically a pharmacist or a psychiatrist with a focus on managing the medications for mental and behavioral health conditions. We've had full sessions dedicated to remote patient monitoring as well. So particularly for someone coming out of the acute care setting, providers may want to monitor temperature, maybe even more often than what the facility nursing staff would be monitoring, weight. Patients with congestive heart failure, for example, temperature could be important for post-surgical patients in rehab. All of those types of vital signs or other biometrics could be primed to consider for remote patient monitoring, coding, and billing as well. With just a few minutes we have left, I want to talk about the hospice certification and recertification for those long-term care facilities that contract with hospice agencies to either provide hospice services to a patient who has become terminally ill, or vice versa. The hospice is contracting with the facility to provide general inpatient level of care or respite care for that matter, for hospice patients throughout their hospice episode. Typically, you're going to have a contract between the long-term care community and the hospice agency. And I'd encourage you to take a look at the state operations manual that's on CMS's website. It goes through a lot of very really specific details on what needs to be in those skilled nursing facility hospice agency agreements, and how you define the plan of care. Will you have two separate plans of care or a combined hospice long-term care plan of care for the patient? Who maintains the plan of care, et cetera. So outside of the contract for services with the hospice agency, though, the hospice certification and recertification is something that has been discussed as a telehealth flexibility, where typically going into the third benefit period for hospice, if the patient reaches that point, the provider certifying the continued need and eligibility for hospice care, that we continue to believe that the patient has a terminal illness, which, if it ran its natural course, would tend to have a life expectancy of 6 months or less. Into that third benefit period typically needs to be an in-person, face-to-face visit to certify the patient's eligibility for hospice. That typically, like I said, is a face-to-face service, but during the public health emergency, going into that third benefit period can be delivered via telehealth right now. After the public health emergency ends, that will need to be provided as an in-person visit again. I thought this was a really helpful FAQ that I just wanted to provide for those facilities working with hospice agencies. It's not really limited to telehealth or to the public health emergency, but it says the statute's actually silent as to whether the hospice certification for the first and the second benefit periods have to be face-to-face. So the agency interpreted that could mean that first and second benefit period certification can be done by a telecommunications technology, either by the hospice physician or hospice nurse practitioner. Keep in mind, though, we have a whole session on palliative care and hospice care from a few weeks ago as well, that If you're in Missouri, and I believe Oklahoma as well, our state rules do not allow non-physician practitioners to serve as the patient's hospice attending physician and separately bill for services, even though Medicare would allow that. Kansas, you're okay. Either the physician or nurse practitioner can serve as a patient's hospice attending physician and bill for their services separately. So kind of the last FAQ here, can hospice services be furnished using telecommunications technology? Yes. That can include, I think this is helpful, can include telephone calls or two-way audio video telecommunications technologies during the public health emergency. So I'm right up at 1 o'clock on the hour. Do we have any other questions in the chat?
I have not seen any additional questions at this time.
All right.
Okay. I do encourage you to email us at htrc@kumc.edu if you have any thoughts or questions that you think of after our presentation today. We will be emailing all of you the recording along with the slide presentation so you can review it in more detail as you have time. I also want to remind you, send us an email if you were not able to attend our telehealth flexibilities extended pop-up webinar last week. I know Rochelle referenced that, so if you think it would be helpful to listen to it again or see it, there was a lot of information. Let us know if you didn't get that link and we can send it out to you. Our next webinar in our education series is on April 20th. And during that webinar, we will be covering guardian responsibilities and issues surrounding consent, privacy, service delivery, and billing in the telehealth context across the lifespan. So please remember to join us during that presentation. And again, you're always welcome to email us and visit our website and send us any questions you might have, and we'll get back to you. Thank you for your time today.